Now, not everything that contains fat is innocuous, okay? And here's a patient who has hepatocellular carcinoma, and we can see on this non-contrast scan that there's a definite fatty component to this HCC. HCC is one liver lesion that has fat in it focally, not terribly infrequently. And here's the corresponding ultrasound with the less affected soft tissue area and the echogenic fatty area. In the next example, we see a contrast enhanced scan where the fatty area doesn't enhance, but the other area enhances quite prominently. And on the color Doppler, we can see that the fatty area does not enhance, but there's very prominent increased flow within the solid, more non-fatty affected component of this hepatocellular carcinoma. So the next point I want to make, which is germane to the diagnosis of fatty liver, is that if you have classic spared areas, these are diagnostic for fatty liver. And this is true even when the overall liver echogenicity is normal. These are some of the areas that are classically affected by sparing. And you can see basically it is the posterior or dorsal portion of the left lobe, ventral to the bifurcation of the portal vein, along the fissure for the ligamentum venosum. And here's an example of this, ventral to the portal vein bifurcation. Here's left portal vein, right portal vein. In this sort of classic pyramidal or triangular shaped area is very typical for sparing and is diagnostic for fatty liver. Down a little bit more caudal, you see the same dorsal left lobe sparing. And of course the gallbladder region is another area that is commonly affected by sparing. And here's one such gallbladder that has a very prominent spared area. Again, don't confuse this for a mass. This is diagnostic for fatty liver. Here's a long axis view. And here again we have sparing adjacent to the gallbladder. And one pitfall here that isn't always appreciated is that people will confuse this for either thickening of the gallbladder wall or more significantly, a pericholecystic abscess. This is focal sparing and should not be confused for anything else. Now here's a classic spared area, diagnostic of fatty liver, but here's a case that's more problematic, and we have a large liver here, but it's not obviously a fatty liver from the images that we have here. However, when we look around a little bit, we see that there is in fact a classic spared area anterior to the porta hepatis, portal vein bifurcation region. And this is thus definitively fatty infiltration of the liver. So sparing alone is enough to make the diagnosis of fatty liver. Let's move on to cirrhosis. Cirrhosis has many causes: alcohol abuse, hepatitis B, hepatitis C, and many other causes, including progression of non-alcoholic fatty liver disease. This is the wine that the patients at the county hospital in Los Angeles prefer, first growth Bordeaux, etc. The primary diagnostic criterion that we use for cirrhosis is a nodular liver surface. To a lesser extent, we use the shape of the liver, the morphology, where you can have a small right lobe and a large caudate lobe, or in my view, an even more useful finding is an enlarged lateral segment of the left lobe, especially when the surfaces are biconvex. Here's an example of a 3D image of a nodular surface in a patient with ascites. And you can see this quite nicely. Unfortunately, we can't get images like this all the time. It's easy to make the diagnosis of surface nodularity when we have ascites, as we do in this case. And this is quite readily diagnosable. But when there's no ascites, it can be harder. Here's a patient who has a large left lobe, small right lobe, and this is, again, cirrhotic morphology and certainly suggestive of cirrhosis. A little bit about liver surface nodularity. A lot of people think that looking at the nodularity of the liver is useless. However, if you use this sign properly, it's quite useful. There's no question that it is an insensitive sign. Now, what does that mean? It means basically that you will encounter many people who have cirrhosis who do not have an apparently nodular surface. This is largely people who have micronodular cirrhosis. Technique is important in trying to elicit whether or not there is nodularity. And one thing that you don't want to do is scan between the ribs and the right lobe. We always scan ventrally in the midline using a high-resolution transducer to see the anterior surface of the left lobe. So one pitfall is, with regard to liver surface nodularity, is that it has a very good positive predictive value, but it's insensitive. So that means if you have an unequivocally nodular liver surface, you can pretty much take it to the bank, with some exceptions, that the patient has cirrhosis. However, it's mandatory to view this either at real time or with video clips to make the diagnosis more secure. Looking at still images, frozen images, doesn't work very well. So what do? We use a high-frequency linear array transducer, although occasionally you can get away with the curved linear transducer if the resolution is good enough. And we scan longitudinally in the midline, looking for the ventral surface of the left lobe of the liver. And as I said, real-time images or clips are mandatory in doing this. You have to be careful to hold the transducer so that the beam is at 90 degrees to the liver surface, because if it's not at 90 degrees, you can get erroneous results. Here's a nodular liver surface with a high-resolution transducer. And I don't think anyone would dispute that this is nodular, and this has a good predictive value for cirrhosis. Now, this is a patient who has liver nodularity, but it's not seen very well because we're using our lower resolution abdominal transducer. Here's the same patient with a high resolution transducer, and you can see how much more clearly it's seen. So technique's important. Sometimes you will see it with a curved linear array if it's a modern transducer, and I think you can appreciate the liver surface nodularity. We have to do this sometimes in patients who are fat or have other body habitus problems that prevents us from seeing things well with the high-resolution transducer. So next hint, liver surface nodularity. Scan the ventral left lobe in the midline, look at the surface. And you have to do this either scanning it at real time or with video clips. Hold the transducer at 90 degrees to the liver surface if you want to get a reliable result. And here's a scan that sort of shows you why I don't like scanning intercostally on the right. And this doesn't really show any nodularity whatsoever scanning over in this location. However, there is nodularity seen. This is very subtle, but it's real, of the ventral left lobe. So scan the ventral left lobe, not the right lobe. The reason we don't, as I said, to emphasize again, scan intercostally, is that it's less sensitive and there are fewer true positives. The one exception to this is when there's a small amount of ascites present, sometimes you can actually see the liver surface better on the right. So if there's ascites out laterally, that can be good and can allow you to make the diagnosis, especially if there's no ascites medially. Now here's one such case that's showing us the nodularity to better advantage with the ascites. Here's another case where the liver surface looks smooth on the left lobe, but looks nodular with ascites through the ribs. So there are exceptions to this, as there are to almost all rules, but in general, left lobe is where you want to be. Now, cirrhosis is not the only cause of nodular liver surface. You can get this with multiple liver tumors, metastatic disease, HCC. You can get it with peritoneal carcinomatosis, where there are implants on the surface of the liver that can cause difficulties. You can get it with acute massive hepatic necrosis, but this is rare, and because we don't usually get these people in ultrasound. Here's a patient who has neuroendocrine metastases and nodularity because of the focal liver lesions, not cirrhosis. And here's another one. This is a nodular liver surface. This patient does not have any liver disease per se, but rather has implants along the surface because of the carcinomatosis from breast carcinoma. Now, just to emphasize, I think that you need to be careful to only say that the liver surface is nodular if it is definitely nodular. If you're not sure that it's nodular, don't call it nodular, because you want to have a very high predictive value for surface nodularity to predict cirrhosis.